Contemporary thought and the mental health professional. Beginning with personality theory, there is not a firmly agreed upon definition. It's been discussed for centuries, going back to Greek philosophers' descriptions of the four humors or bodily fluids, which included black bile, yellow bile, blood, and phlegm. Its attempts to determine personality through physical characteristics with things like phrenology, which was feeling for and trying to assess the bumps on someone's head to determine what type of person they were, criminal intent, psychotic things, different things like that. That was described by Franz Gall. And then things like body types, which were discussed by William Sheldon, and there are lots of other body type descriptors trying to figure out character structure coming all the way into this day. Oftentimes, personality is defined as an individual's way of behaving, thinking, and acting. Person's prominent qualities tend to stay stable throughout a person's life, but subtle changes do end up taking place. So personality traits are internally based characteristics that are multidimensional. I'm going to start with psychoanalytic theory and psychoanalytic approaches. This has probably been talked about ad nauseum in other courses around psychology, but just to kind of really re-emphasize some of the paradigm traits around this. So Freudian really came up with 3 levels of awareness and 3-part personality structure. So he talked about consciousness, the id, ego, and superego, and then of course defense mechanisms. So when we think about consciousness, it's about what you are aware of in the present moment, and it is related to short-term awareness. There is pre-conscious, which is stored memories that are outside of present awareness, but you can access them. And then there is the unconscious, which is not accessible freely. It contains our primary motivations for actions, feelings, and instinctual drives. It is all of those things that are repressed. So the emphasis is really on unconscious forces and childhood experiences. And this is where the whole idea behind lay down on the couch and just start talking, which is called free association, which is a big deal in psychoanalytic approaches. So the id, the levels of structure, the id, which is the deepest or most primitive aspect where the base animalistic drives are housed. This is Freud's explanation of the pleasure principle, where immediate gratification and no concern for the consequences. Ego, which is the second part of the personality structure, really helps to temper and constrain the base urges of the id. Freud talks about the reality principle, where gratification can be found within the bounds of reality, and then superego, which is representative of conscious and idealized standards of the self. It's really in charge of morality, and the ego is kind of the go-between between the id and the superego. Defense mechanisms tend to distort reality and act as protective devices used to help us deal with overwhelming life events like unacceptable feelings, memories, or thoughts. So some of the defense mechanisms are repression, regression, denial, displacement, sublimation, reaction formation, projection, and rationalization. Freud also talks, and in psychoanalytic theory, a lot of talk about psychosexual stages. These are developed from his own childhood memories and the memories of his patients. These stages have 2 primary concepts of erogenous zones, or parts of the body related to the id pleasure-seeking principles, and fixations where development does not move beyond that stage. So those stages are oral, which is birth to 1.5 years, anal, which is 1.5 to 3 years, phallic, which is 3 to 6 years, latency, 6 years to puberty, and genital, puberty through adulthood. Some criticisms of the psychoanalytic approach are many, but it is worth noting that Freud did lay the foundation upon which modern psychology was built, and his work really paved the way for others. So there were people that then came along. They were either contemporaries of Freud or they were students of his, and they are called neo-Freudians. Erik Erikson, Carl Jung, Alfred Adler, Karen Horney, they're some of the most prominent. Erikson really developed psychosocial stages of development. Jung delved more deeply into the unconscious, giving way to vast amounts of work with dreams, mythology, and symbols. Adler believed that inferiority serves as a human basic motivator, and Karen Horney worked, her work was in the realm of security and attachment and the importance of interpersonal relationships. The humanistic approach was developed in the 1960s in response to deterministic and behavioral-based approaches. Abraham Maslow was one of the most prominent persons in this in this realm, and so most of us have heard about Maslow's hierarchy of needs, which is pictured here. So the hierarchy of needs is fulfilling these needs in order to reach one's full potential is ultimately the goal. So the basic needs of physiology must first be met, along with safety, security, stability, and then you can move up from there. So the basic needs, psychological needs, and self-fulfillment needs as we kind of get higher up our triangle. So the focus on needs being fulfilled for growth to happen. So his theory has really been criticized for it lacking any kind of empirical evidence and being based on his bias, regardless of the fact that it has persisted for 60 plus years. So Carl Rogers was a clinician in an academic setting working with young people, and he too saw self-actualization as the primary goal for development. He was client-centered or person-centered therapy is what's often attributed to him. Self-concept related to self-worth, and that we want to be positively regarded in relationships leading to traits of empathy and respect for others. So a phrase that is often attributed to him and connected to Rogerian therapy is unconditional positive regard. It is what Rogerian therapists hold for their clients as a way to help them toward that self-actualization. Both of these are really focused on self-actualization as a goal. Social cognitive, it's a combination of behaviorism, social learning, and cognitive processing. Many people know of Albert Bandura talking about self-systems, self-efficacy. Julian Rotter talked about the external locus of control, internal locus of control, and learned helplessness. So external locus of control is really having something outside of us be the true driver in why we behave. So an example would be a student in school is wanting to get a good grade, wanting to get an A in a class. That is an external locus of control, whereas someone that has more of an internal locus of control, they want to get a good grade in that class because they want to learn, they want to improve, they want to increase their own internal sense of knowledge and control. And so then that's somebody that has more of an internal locus of control. And then there's learned helplessness, which there's a lot of talk about that nowadays as we start to understand more things around trauma and some of the conditioning that people experience in the environment that they find themselves in. Self-perception is part of social cognitive theory, and we talk about attribution and self-serving bias. And this is really about how we see ourselves and how we attribute certain goals and certain attainment of things if we attribute that to ourselves or to someone else, which it kind of has some connection to the locus of control. However, it is a little bit different. In trait theory, characteristics unique to an individual, meaning that there could potentially be thousands of traits. So trait theory seeks to find out how many traits are actually necessary. It uses statistical techniques, factor analysis, identifies clusters of test items. In the 1930s, two researchers began with 18,000 words, narrowed it down to 200 clusters, which was then reduced later to 5 basic traits all individuals have. There is debate about the number. What is important to remember is that there is complexity and nuance that is being accounted for. Heinz-Isaacs three-factor theory determined by hereditary with a biological basis for each. So 3 trait dimensions, extroversion and introversion, having to do with sociability, related to levels of arousal in the cortical region of the brain. There are brain scan studies to support this. Neuroticism, emotional stability, is relating to emotional states and connected to the limbic region, and psychoticism, impulse control, which is related to neurotransmitters and hormone levels. So there is a lot of research in this theory. However, most studies show support for 5 traits, not just 3. The split really happens with psychoticism, which is divided into 2 parts, conscientiousness and agreeableness, with openness being added. This kind of leads us to the 5-factor model, which is formulated by Robert McCrae and Paul Costa, each having high and low end dimensions. So for openness, low would be conforming, narrow interest, closed to new ideas. High level of openness would be independent, broad interest, receptive. Consciousness, low consciousness would be disorganized, careless, impulsive. High levels of consciousness would be dependability, being careful, being disciplined. Extroversion, low, would be reclusive, aloof, cautious. High levels of extroversion would be sociability, talkativeness, adventurous. Agreeableness, low, would be tough-minded, irritable, rude. High levels of agreeableness would be sympathetic, polite, soft-hearted. Neuroticism, low, would be calm, secure, self-satisfied. High levels of neuroticism would be emotional, overly emotional, insecure, nervous. There's validity in findings around this. They have been observed across gender, languages, and culture, not just in westernized societies. They show about a 50% heritability rate across multiple cultures, generally consistent, from age 30 on, over time and in varying situations. So much so that there are personality assessment instruments that provide profile information showing reliability and validity. Talking a bit about assessments, which I'll get into a little bit later in another PowerPoint. It's used to aid in the diagnosis of mental health conditions. These are tests that are developed by theorists, and there's really 2 main categories. There's personality inventories, and then there's projective identifications. So personality inventories are designed to measure multiple traits, oftentimes true or false, yes, no questions. Occasionally includes can't say or uncertain. These are really based on self-report. Test taker reports whether it applies to them or not. So there's things like the MMPI revised to the MMPI-2, which has been translated into more than 100 languages, used throughout the world. It was developed in Minnesota in the 1940s. It is long, nearly 600 questions that are objectively scored. Revisions took place in the 1980s with changes to wording and the removal of several questions that were used originally to determine homosexuality. So just kind of remember that homosexuality was considered a personality disorder until about 1962 in all 50 states. It was considered a crime. Projective identification uses ambiguous stimuli, which the examinee responds based on their perception. It's not scored objectively. So the thematic apperception test was developed in the 1930s, consists of 31 cards of black and white pictures. The test taker is shown the card and asked to tell the story of what happened or describe what they see, how people in the picture are feeling, or what they are thinking. The Rorschach inkblot test, which a lot of people know about, most people have some idea of this. The test contains 10 monographs originally created to diagnose schizophrenia by a man named Hermann Rorschach, who was a Swiss psychiatrist. This too is a tool of perception, with the respondents' responses revealing personality conflicts and personality dynamics. A main criticism of these two and other projective identification tests are lack of validity and reliability. However, proponents of these types of tests use them to explore aspects of a person's personality in a way that more quantifiable tests cannot and do not do. All right, so there's just a ton of stuff on this slide. Really, what I want you to know is that mental health professionals and mental health practitioners, there is some type of formal training. Each of them has a governing body that provides ethical oversight as well as licensure requirements, and these do vary by state and profession. So just kind of some quick overview. You can pause this and take a look at these things in more detail if you'd like. Is that alcohol and drug counselors? It really truly began as a grass movement to help those people with substance use disorders. It was more often than not by other people who were sharing their own stories and understanding of how to recover from primarily alcohol abuse. So if you know anything about the origins of AA, Bill W. And Dr. Bob, they kind of work together and really, getting together and talking with each other and sharing stories and strengths and hopes around how to manage and to deal with some of their alcohol abuse issues. That's just kind of where things started. Eventually, these stories and these get-togethers eventually broadened to multiple substances and even to process disorders, which will be discussed in a separate PowerPoint. So you can take a look on here. Again, there's like clinical counselors, marriage and family therapy, psychiatrists, psychologists, social workers, and each one of them, again, has schooling requirements, licensure, continuing education, and boundaries around which they are meant to function. One thing I do want to point out are peer support specialists or pastoral counseling. So these are people who may gain certification in their area of interest, and many of them have or go on to obtain advanced degrees. These are truly some of the backbone of a lot of support for these other mental health professionals. Again, huge amount of information on here, but you can just take a look. There is certification requirements, enrollment requirements, again, just kind of a breakdown, and then some of the governing boards, the Board of Nursing, mental health, social work, Board of Psychology, things like that. So in summary, describing and defining personality, there's a long history of people wanting and needing to describe and categorize people and their behaviors, beginning with philosophers and continuing to this day with a variety of specialization. Freud, with his psychoanalytic approach, was prolific and controversial in his work, but he did lead things to create and explore through their own thoughts and ideas about how to explain behavior, personality, lots of offshoots, really looking at things like the inner workings of human beings, including humanistic, social cognitive, and those trait theories. The psychoanalytic approach, humanistic, social cognitive, and trait theory, to name just a few. Some of the assessments, which are pretty important to take into consideration, and it's an important part, development as a way to create uniformity in how personality traits are viewed, categorized, and even treated. And then, of course, the mental health professionals with the varying levels of training and licensure, with specializations in understanding and focus of assessments and treatments. And here are your references.